Good morning. I'm Reg Sanders, and I'd like to thank our organizers for putting together such a fantastic program. This next section is going to be an update on neovascular AMD, and our first speaker is Judy Kim out of now Texas, who's going to update us on imaging for neovascular AMD in 2024. Dr. Kim?
Thank you, and good morning, everyone. When we speak of imaging in neovascular AMD, of course, there's color fundus photograph, which we can use to document its location and extent, as well as associated findings. While fluorescein dye was introduced into the field of ophthalmology in 1882, it took two medical students in 1961 to show that fluorescein angiography can be performed in humans. Fluorescein angiogram has allowed us to perform many clinical trials that brought laser and surgery as treatment option for neovascular AMD. It confirms the presence of CNVM, as well as location, size, and extent of hemorrhage and fibrosis, and monitor the growth. We classify neovascular AMD based on fluorescein angiogram leakage, namely classic, occult, and combination. However, in the era of OCT and anti-VEGF, millennials are never taught, and we often don't use classification based on fluorescein angiogram because we now have non-invasive in vivo biopsy of the retina in the normal state as well as in disease states such as neovascular AMD. Recently, OCT-based macular neovascularization classification has been developed. In type 1 MMV, the growth of new vessels are from the choriocapillaris into the sub-RPE space. In type 2 MMV, growth is through the RPE and located above the RPE at subretinal space. And there can be a combination of type 1 and type 2 MMV. Type 3 MMV, or retinal angiomatous proliferation, has been aided by the OCT in being able to classify the different stages, 3 stages of its development. It is also important to know polypoidal choroidal vasculopathy findings in OCT, which we call type 1 aneurysmal, where there are branching neovascular networks and aneurysmal dilatations under the RPE. Why is it important to differentiate PCV from typical neovascular AMD? Because it is associated with larger dramatic hemorrhages and recurrences, and it does not respond to all anti-VEGF equally and may need combination therapy with photodynamic therapy. Despite this, it is often underdiagnosed in Caucasians with neovascular AMD. While indocyanine green angiography has been the gold standard for detecting PCV, showing these polypoidal lesions quite well, it is invasive and cumbersome to use. Therefore, my colleagues and I at Asia Pacific Ocular Imaging Society PCV work group has developed non-ICGA diagnostic criteria. We found that 3 characteristics on OCT, namely sub-RPE ring-like lesion, sharply peaked PED, as well as complex RP elevation seen on on-FOS OCT, give high predictive value, sensitivity, specificity, and AUC. Of course, OCT can show us other findings in neovascular AMD, such as RPE tear, fibrovascular PED. In late stages, we may see cystic spaces as well as outer retinal tubulation. It is important to recognize these because we do not need to treat them with anti-VEGF. Then OCT angiography has shown us a lot more information about choroidal neovascular membrane, and various interesting names have been given. Multimodal imaging, such as combination of fluorescein angiogram, structural OCT, as well as OCT angiography with flow overlay, will give us functional information showing the activity of choroidal neovascular membrane. However, we often do not use OCTA in the clinic because this is what we often get in the clinic, And it's only after we spend more time afterwards with manual segmentation that we get these beautiful images. And as a result, we often do not use it in busy clinics. In fact, when ASRS PAT survey asked, how do you image new onset coronary vascular membrane in wet AMD? Little over half said they combined fluorescein angiogram along with OCT at baseline. However, almost 40% do not use fluorescein angiogram at all. So what happens in the future? Well, as you know, 2 Nobel Prizes went to those who developed AI, artificial intelligence, or used artificial intelligence. And even in retina, we often see publications based on AI and neovascular AMD, and the number is continually increasing. I believe that in the future, multimodal imaging combined with artificial intelligence will help us with therapy, but also I would add telemedicine in here. Why? Because 5 months ago, as Dr. Martin stated, FDA granted de novo authorization to home OCT. It is the first retinal home imaging device that uses OCT with artificial intelligence. When patients take daily scans, these B scans are processed by AI and provides temporal information about fluid recurrence. And it is important in this telemedicine that we have monitoring center to appreciate the success of home monitoring. We have seen that disease response to treatments are quite heterogeneous, and we can separate out good responders from poor responders earlier with home OCT. We can determine the treatment interval faster, and even withhold treatment if necessary with home OCT, with the understanding that there is a safety net with home OCT that will determine and capture the recurrence of fluid, as well as monitoring not only the diseased eye, but also possible conversion in the fellow eye. So as we leap into the future, I believe multimodal imaging combined with artificial intelligence will help us to determine the therapeutic response, and this will become more and more important as we go on to more durable therapies. And telemedicine will play a bigger role as we move towards personalized treatment in neovascular AMD. Thank you for your attention.
Thank you, Dr. Kim, for an excellent talk. Our next speaker is one of our organizers, Dr. Barbara Blodi, and she's going to talk to us about macular atrophy in the anti-VEGF era. Dr. Blodi?
Thanks. Good morning. I'd like to start off with the introduction that we're going to touch on a subject, macular atrophy in the anti-VEGF era, that's an old topic, but with some new research findings. I'd like to thank the Reading Center staff at the University of Wisconsin, as well as Genentech for funding this research. I have no financial conflicts of interest. So just to take us all back to the beginning of the anti-VEGF era, that began really around 2006. The first drugs were bevacizumab and ranibizumab, and we all saw, those of us in practice then, saw that monthly injections led to some amazing improvement in vision and changed the natural course of neovascular AMD. Today, I'm going to focus on the MARINA phase 3 trial that was done at that time. This was a trial that enrolled eyes with minimally classic and occult CNV, and there were 3 arms to this study, 2 doses of ranibizumab and a sham control. The treated patients received monthly injections for 2 years with fundus photograph and fluorescein at baseline and follow-up, and the 1-year primary outcome, ranibizumab, met that primary outcome with a 7-letter improvement versus a 10-letter loss in the sham or control group. The goal of this talk is to focus on a post-hoc analysis on the prevalence of atrophy in treated and untreated eyes with neovascular AMD. This analysis is unique to this trial because it's the last clinical trial we have with a sham arm. And here you can see the landmark study that was published in the New England Journal of Medicine 2006 showing the benefit of the ranibizumab in neovascular AMD. It was about 8 years later that we started to hear about atrophy. And these were some great publications highlighting atrophy in CAT, 2 years and 5 years, in IVAN, in the Harbor, and in the rival trials. But these publications were missing something. The question about, is this atrophy natural history, or is the atrophy a treatment effect, could not be answered in these papers because there's no control group. So I'm going to get back to Marina. Marina then recently had a regrading for atrophy. Post hoc regrading protocol looked at atrophy by using planimetry, the area and presence of atrophy. Fluorescein was used to confirm. The graders also at the University of Wisconsin looked at the location, whether that was within, adjacent, or separate from the CNV lesion. And at baseline, before anyone had treatment, there was a balance across all three arms. The lesion area and the leakage area were comparable. There was no fibrosis at baseline and no atrophy. So I'm going to jump right to the results. I'm going to show you this histogram, showing us those patients with follow-up. They had no atrophy at baseline. At month 3, you can see that there's already some atrophy. The gray and the black bars are the treated groups. This increases at month 6, a steady increase at month 12, and at month 24, the last visit, is a highly statistically significant difference between the amount of atrophy in the treated groups. The 2 doses were at 38 and 40% versus the 21% prevalence of atrophy in the sham group. So what does it look like? In many of these eyes, these Marina-treated eyes had occult CNV. Here's an eye at baseline with a lot of leakage. The leakage is now much less at month 6, but quite a dramatic change at month 12 and 24, where there's now geographic atrophy or macular atrophy in the place of that lesion. We did at 2 years a multivariate analysis of variables that might play a role at that 2-year time point. This analysis showed that only the absence of fibrosis, that was correlated with the increase in atrophy. Which makes sense. If you don't have fibrosis, it's easier to see the atrophy. But fibrosis was really a small part of the lesions in this trial, developed in 5% of the treated eyes and 12% of the sham eyes. Development of atrophy was not correlated with vision, fellow eye atrophy, change in leakage or area, or treatment. The additional results showed us that atrophy did not impact visual acuity outcome at 2 years, and this atrophy did occur within or next to the lesion itself, and you can see that change from baseline to month 24. The limitations of this study, however, this regrading and post-hoc analysis, is there was no OCT or autofluorescence, and that was not available at the time. So autofluorescence and OCT are the primary imaging systems that are used to assess atrophy in clinical trials, and in clinic we really rely on OCT. You can see a baseline CNV lesion. This is not from the Marina trial, but CNV lesion with fluid, and monthly treatment led to central geographic atrophy. In conclusion, the anti-VEGF treated eyes in the Marina study developed a significantly higher percentage of atrophy compared to control. Atrophy occurred as early as 3 months and increased at each subsequent visit up to 40% at 2 years. Atrophy may be undetectable under the areas of fibrosis, but this doesn't explain why atrophy develops faster. Take-home points for us as clinicians: we want to monitor eyes for development of atrophy. As we continue, we need the anti-VEGF medication. But if fluid has resolved or remains stable in some patients, we definitely can consider less frequent dosing. And here's the reference to the article that was published late last year. So thank you for your attention.
Thank you, Dr. Blodi. Our next speaker, move the slides, please, is Dr. A Zarbin, who's going to speak about the impact of disease activity criteria on dosing interval in patients with neovascular AMD. Dr. Zarbin.
Thank you, and thank you all for giving me an opportunity to speak to you today. I want to acknowledge the contributions of my co-authors. These are my disclosures. The relevant one is circled. The take-home message of this talk is that the definition of active disease in clinical trials affects the estimates of drug durability that are derived from those trials. So treatment decisions in clinical trials are driven by disease activity criteria that mandate when an injection has to be given. And I think for most of us, when we're treating patients with neovascular AMD, things that drive our decision to treat would be change in vision, change in the OCT, new macular hemorrhage. Unfortunately, different clinical trials use different disease activity criteria to drive dosing, and that complicates our ability to discriminate the durability of the different agents based on the different trial results. So, for example, in the phase 2 Candela trial, 2 milligram aflibercept was compared with 8 milligram aflibercept, and there were disease activity assessments at weeks 24, 28, and 36 and 40, and if active disease was present, an injection was given. And in this trial, either a loss of vision or a change in anatomy mandated an injection. Now, in contrast, in the much larger phase 3 Pulsar trial, 2 milligram aflibercept Q8 was compared to 8 milligram Q12 and 8 milligram Q16 with disease activity assessments at weeks 16, 20, and 24. But in contrast to Candela and Pulsar, a change in vision and a change in anatomy were required to mandate an injection. So when we see that in Candela, about 57% of the patients could be controlled with injections every 12 weeks or longer, it may not be surprising that in Pulsar, 83% could be maintained with injections every 12 weeks or longer. Well, in Tenai and Lucerne, 2 milligram aflibercept Q8 was compared with faricimab 6 milligram, and among the patients randomly assigned to faricimab, there were disease assessments at weeks 20 and 24. Now, in this trial, if there was a change in vision or a change in the OCT or new macular hemorrhage, an injection had to be given. And at years 1 and 2, about 78% of the patients could be maintained with injections every 12 weeks or longer. Among the patients with active disease, about 70% of them had a change in the OCT, about a quarter of them change in vision, and about 10% of the new macular hemorrhage, which I think mirrors what we see in practice. But the point I want to make is that if any one of these events occurred, clinicians administered the faricimab because each event is independently indicating the presence of active disease. Well, we wondered what the durability estimate would be if the disease activity criteria were modified to resemble those of the Pulsar trial. So to answer this question, we did a post hoc analysis of the data. And at week 20 in Tenai and Lucerne, there were 123 patients with active disease. This meant that they had a change in vision and or a change in anatomy and or new macular hemorrhage. If we required that there was both a change in vision and a change in anatomy, then the number of active patients was reduced from 123 to 20, which is an 84% reduction. So it's, the effect of this change in the definition of disease activity was to extend the durability estimate from 78% to 96% of the patients being maintained with injections Q12 weeks or longer. Well, it's interesting that recently a study was reported by the Moorfields group, 50 treatment-naive neovascular AMD patients treated with faricimab, and this was reported at ARVO. They measured disease activity with vision and anatomy, as we all do, and they applied hypothetical disease activity criteria from Tenai, Lucerne, Hawk Harrier, and the Pulsar trials to determine the potential impact on the decision to extend the treatment intervals, and the results are shown here. And what you can see reproduced is the idea that depending on the disease activity criteria used, you get different estimates of the durability. And as we found, the Pulsar criteria gave the best, longest estimate of durability. And the point I'm trying to make is that depending on the disease activity criteria that we use, the same drug can give different durability estimates. In this case, it was faricimab. So in Tenai and Lucerne, a disease activity criteria which allowed either a change in vision or anatomy to mandate an injection, I think more closely resembled routine clinical practice. And in the majority of cases, it was the OCT that drove the decision. And that's, I think, also reflective of how we normally practice. When we require a change in vision and anatomy to mandate an injection, we're going to probably see an increase in the durability estimate, which is what we observed in the post hoc analysis of the Tenai and Lucerne data. And this may perhaps underlie also the difference in the durability estimates that were reported in Candela and Pulsar. I think that using criteria that reflect real-world clinical practice is going to increase the likelihood that the clinical trial results are actually going to be reproduced in our clinical practice. Thank you all very much for your attention.
Thank you, Dr. Zarbin. Our next speaker, you have the slides up, please, is Dr. Usha Chakravarthy, who's going to speak to us about biomarkers for fibrosis in treated neovascular age-related macular degeneration.
Thank you, panel chair. Here are my disclosures, none of which are relevant to the current presentation. So I think all of you in the audience would agree that the second panel shown on the left on your side is a case where there's macular fibrosis, very obvious, very prolific. However, after the introduction of anti-VEGF, you can see that, that there are cases which have very subtle, almost undetectable fibrosis. And this can confound our detection in terms of reporting the prevalence and incidence. And in the IVAN and CAT meta-analysis, which was performed, we observed that fibrosis did develop despite protocol-directed treatment frequencies. And this was based on color image grading. And when there was a suboptimal fluid control, such as those eyes that had much more severe disease, the risk of fibrosis was greater, as was the risk of worse functional outcomes. In a meta-analysis that was performed some years after the treatment of anti-VEGF was introduced, you can see a great deal of heterogeneity in both prevalent and incident fibrosis. And if you look at the diamond at the bottom of the graph, you can see that the rates of reported fibrosis range from 20% to nearly 100%. And a systematic review in which I was involved in showed that there was a considerable heterogeneity and lack of homogeneity in the way in which fibrosis was defined. And this was particularly so when spectral domain OCT was used as the imaging modality. Now, obviously, color images have a variety of different confounders, including medial opacities, poor focus, and illumination. And the hyperreflective material that's used as a proxy for the presence of fibrosis on OCT is much more reproducibly detected by retina specialists, and also it gives you depth information. You can locate it to whether it's subretinal pigment epithelial, replacing the outer retinal tissue. You can look at all these characteristics. In the IVAN trial, again, after 7 years of follow-up, we observed that the presence of structured, defined, hyperreflective material in a relatively quiescent eyes, when it was persistent, was strongly associated with poor visual function. And this, of course, means that's an important biomarker. However, we have hardly any data on the agreement between our standard imaging modality, which is color, and has been used forever with the definitions entrenched in the literature. So we tested the agreement between color, fluorescein, and spectral domain OCT in 130 eyes after 18 months of treatment initiation. And the data repository that we used came from the EDNA study, the reference of which is shown at the bottom of the slide. Our graders assessed the presence of fibrosis on color, fluorescein, and OCT in this order, and we observed that the agreement between color and fluorescein angiography, both established modalities, was only 0.56 of a kappa, and with color versus OCT was 0.4. However, when we reclassified the data into whether the hyperreflective material was internal or external to the RPE, that is, when it was subretinal, there was a much greater agreement both with color and with fluorescein with spectral domain OCT. So we set up an international fibrosis consensus group. We had our inaugural meeting in February this year, and we considered the strategies and next steps in moving towards development of a consensus for identifying and validating, identifying fibrosis and validating clinical trial endpoints. And we did this through the International Retina Imaging Society, and Gemmy and Marion Monk took over this role of developing the forms, writing out to the interest members, getting agreement for them to take part in this exercise. I'm just going to show you a very preliminary result. It's very, we obviously have plans to expand this further. So this shows the fibrosis detection by retina experts from the Interest Society, and you can see 10 cases have been looked at. This is the sort of line giving us the proportions of times when there was greater than 75% agreement in a case. The turquoise bars representing the nose, and the gold bars representing yes. And as you can see here, that 5 times out of the 10 cases, agreement was just over 75%. And with spectral domain OCT images shown below, the bar graphs indicating that this occurred around 7 times. Not a great deal of difference. But I just want to point out 2 things. In case number 117025, you can see that there was 100% agreement on color, but when spectral domain OCT of the same eye was presented to the experts, they disagreed around 30% of the time. And here in another example, you can see that agreement was more in favor of a presence of fibrosis on color, but this flipped over to the other side. So our take-home messages are as follows. Agreement between color-detected fibrosis and hyperreflective material improves when the location is subretinal. Agreement varies between color and spectral domain OCT and is modest at best, regardless of imaging modality. And of course, there are impediments now to establishing accurate prevalence and incidence, and this includes lack of precise definitions of bioimaging modalities, suboptimal images, and assessments reported at variable time points. Now, we have to address all these as we progress towards therapies that may prevent or delay the onset of fibrosis. I'd like to thank all members of the Interest Society who took part in this exercise, and thanks to Gemmy and Marion for their help with this. Thank you.
Thank you, Dr. Chakravarthy. Our next speaker for this section, slides up, is Dr. Gemmy Cheung, who's going to speak to us about current treatment of polypoidal neovascular AMD. Dr. Cheung.
Thank you very much for the introduction, and thank you for the opportunity to speak today. These are my disclosures, and I'd like to acknowledge my funders as well as my co-worker, particular Dr. Kelvin Tew. Here are my take-home messages. Anti-VEGF monotherapy can effectively bring us visual acuity improvement in the majority of eyes with PCV. However, OCTA observations highlight there's a great deal of differences and heterogeneity in both the phenotype and the treatment response in the 2 parts of the lesion, and future studies should address these to improve the treatment outcome. As mentioned earlier on, polypoidal neovascular AMD, also got other names, PCV, AT1, differs from typical neovascular AMD in that there are 2 lesion components, making the treatment response more complicated. In fact, the actual nature of each of these lesion components is still debated. Using OCT angiography, we recently discovered that in PCV, the branching neovascular network tends to display a more mature network compared to typical neovascular AMD, as shown in this example, whereas the polypoidal lesion shows a much more active, tightly coiled vasculature with focal dilatation inside. And you can see the 2 parts are connected by a segment of vessel highlighted by the green arrow in that cartoon. Now, back in the days when there was only Lucentis, combining anti-VEGF with PDT was very popular to use because of the very high or much higher proportion of eyes that can achieve polypoidal lesion closure that was demonstrated in the EVEREST-2 study. So if we look at the OCT angiography of such eye, treated with combination, you can see very rapid closure of that whole complex at month 3, staying closed at month 12. And in the corresponding OCT angiography, you can see obliteration of the flow within the polypoidal lesion. On the branching vascular network, you can see reduction in the vessel density at month 3, but at month 12, there is some return with finer vasculature coming back. Unfortunately, when we follow up to 6 years of some of those original EVEREST-2 study participants, we found that the initial polyp closure or the initial randomization arm didn't actually confer a long-term benefit, not for BCVA nor for the long-term retreatment need. Perhaps one of the reasons is reopening of the polypoidal lesion, as demonstrated in this case. This case actually was treated with PDT combined with aflibercept. Here, the ICGA. Note that there is no fluid, but on the OCT angiography, this is really intriguing. You notice that there's progressive stabilization or remodeling of the branching network with decrease in vessel density, yet concurrently there is increase in flow within the polypoidal lesion, and that is one of the kind of enigmas right at the moment. Why is there apparent paradoxical response in the 2 parts of the lesion, and what is the interaction between the 2 parts? But coming back to the question of therapy, monotherapy with anti-VEGF today, I would say, is the most commonly used strategy. This was popularized after the PLANET study demonstrating BCVA gain, 80% of eyes with a dry retina, despite a lower proportion achieving polyp closure. Subsequent studies also evaluated using T&E approach with aflibercept, again showing good BCVA benefit as well. Let's look at a case example. This is at baseline. Note that when treated with monotherapy, there is gradual, much slower reduction in the flow within the polypoidal lesion, different from the tandem that we saw just now using combination therapy. There's relatively less change in the branching network, and we continue to see that stalk that initially was supplying that polypoidal lesion. Here is a different case showing you, again, very tightly coiled vasculature within the polypoidal lesion. There are a couple of focal dilatations and a very hypermature network. With monotherapy, look at the OCT. We've got a dry retina, yet on ICGA, the polyp is clearly perfused, and so is on the OCT angiography. Actually, after a number of treatment, at month 12, we actually see a gradual increase in the flow within the polypoidal lesion. But looking at the BNN, the branching network, there is very little change overall. There is still a stalk connecting the two paths, and here I highlight there may be some new fine vessels appearing closer to where the polypoidal lesion is. This may be the area that is feeding the recurrence of the polypoidal lesion. What if we combine PDT to aflibercept? This is a less studied area. The Atlantic group looked at adding PDT at week 16 to aflibercept monotherapy and found that there is little differences in the BCVA gain. More recently in Singapore, we have just completed an RCT in which we compare baseline combination therapy, which consists of reduced fluence PDT with aflibercept 2 milligrams compared to monotherapy with aflibercept 2 milligrams and following a 1+ PRN protocol up to 12 months. On the right-hand side, the bar chart shows you that combination achieves double the rate of polypoidal lesion closure at month 3, continuing to be numerically higher at month 12, although there is some catch-up with the monotherapy group. But what is interesting is in terms of BCVA gain, there is actually only less than 1 letter difference between the two arms, despite such big differences in the anatomical outcome. So showing you some cases, again, this combination following PRN, there is transient reduction in the flow at month 3, which comes back at month 12. Similar picture on OCT angiography. Here are the stalk, and there is a focal dilatation, but within the polypoidal lesion, you can see that there is a very complex spiral of flow within that, and this is different from the perspective we get from OCT when the flow is very homogeneous. With the branching network, you can see that in one area there's reduction in flow, and in another area there's appearance of new fine vasculature. Other newer therapies with brolucizumab, this has been demonstrated to be able to give us visual acuity gains similar to aflibercept monotherapy in the HAWK Japanese PCV subgroup analysis. 76% were maintained at Q12 weeks or longer. With faricimab, this is currently evaluated in Selwyn with a 4+ up to Q16 week regimen, and the 16-week interim data will be released first time at the APVRS in Singapore next month. And finally, with the Pulsar, we saw one of the biggest PCV subgroup analysis available with 140 or 139 patients to be exact, reporting similar visual gains in the PCV subgroup compared to the overall population. Again, large proportion were maintained on Q12 or longer interval, but anatomical responses were similar to what we saw with 2 milligrams. So with that, I'd like to conclude. So the simple message is anti-VEGF monotherapy works in the majority of patients, yet there remains a whole lot of heterogeneity, and in some cases, even if we throw combination to these eyes, we can't close the polyps. That remains an area of unmet need. Thank you very much again for the opportunity to share with you.
Thank you, Dr. Cheung, and all our speakers. That concludes this section. Our next moderator is Dr. Paul Sternberg.